Good evening, and thank you for attending the webinar put on by Dr. Roussin and his team. The title is Addressing the Syphilis Surge. I am the Registrar at the College of Physicians and Surgeons in Manitoba. I'd like to start by acknowledging our land, by the CPSM land acknowledgement, We acknowledge that we are hosting this meeting on Treaty 1 territory and that CPSM regulates the practice of Western medicine on Treaty 1, Treaty 2, 3, 4, 5, and Treaty 5 adhesion territories. CPSM respects these treaties. We recognize that these are the ancestral lands of the Anishinaabe, Anishinaabe, Dakota Oyate, the Sinuline, and Nehotawak nations, and the homeland of the Red River Métis. CPSM registrants have the privilege of serving and providing care to Indigenous peoples on these lands. It is an honor to practice Western medicine, and we thank Indigenous peoples for their land stewardship. Welcome. I'll turn it over to Dr. Roussin to do the introductions and to proceed. Thank you.
That's great. Yeah, thanks so much, Dr. Jomek, and thank you to the college for putting this on for us. It's much appreciated. Thanks to Docs Manitoba, who's helped us put on a webinar last month and has got the word out for this webinar too. So really appreciate that. And of course, thanks to everyone for joining us tonight. I guess we'll start with our slideshow here, and we have a number of presenters. Probably none of them need much of an introduction. Really grateful for them to take time out of their day to be with us tonight, and I'll probably just have everyone introduce themselves as they come on. So we're addressing the syphilis surge in Manitoba. We are right now in a crisis of STBBI in Manitoba, really seeing some of the highest rates in the nation in pretty much all the STBBIs, but really concerning numbers in HIV and syphilis. And of course, we are dealing with this syndemic, right, co-occurring epidemics of injection drug use along with syphilis, and then seeing really tragic outcomes with congenital syphilis. And so we really want to get that message out to physicians who, despite many things that we need to address with homelessness, injection drug use, there's a huge role for physicians that are playing now, and we hope to continue to play a larger role. So, so we're going to go through that epidemiology. We're going to talk about the diagnosis and treatment. Discuss the real concerns in congenital syphilis, and then where that public health reporting is important, right? That's really at the junction between public health and primary care, and we really don't want anyone to have any second thoughts about testing, because there's always going to be supports there if you're not sure how to interpret the results. But we want to try to instill some of that knowledge here tonight, especially with testing and when empiric treatment is necessary. So on the next slide, I think is just the overview. So yeah, we're going to take this right from the epi right down to testing, diagnosis, treatment. And then again, where that contact tracing can come in right at that junction between public health and primary care, where we can really address some of these transmission chains. And so again, thanks for joining us. I'm going to pass it right off to Dr. Carol Kurbis to take us through the epidemiology.
Great. Good evening, all, and really appreciate the opportunity to share more information about syphilis in Manitoba. So this slide illustrates the rapid increase in syphilis that we've seen in Manitoba over the past 5 years. It really provides a good visual summary and a background on why routine screening is really an essential part of our strategy to reduce STBBIs. And given the numbers in Manitoba, why really all providers need to be prepared to test, stage, and treat syphilis cases as they present for care. So this data presented on this slide represents infectious cases only, which reflect primary, secondary, and early latent stages of syphilis. Our staging data is still coming in for 2022, and we anticipate the 2022 numbers will be higher than what's shown here. Manitoba, unfortunately, has the highest rate of infectious syphilis diagnoses of all Canadian provinces, and we're surpassed only by Nunavut. The total number of positive test results has tripled since 2018, and while there was a decrease in screening during the pandemic, it's since returned to pre-pandemic levels. The slide also provides a breakdown between cases in males and females, and over the past decade, there's really been a shift in the patterns of transmission in Manitoba. So earlier in the decade, there was a predominance of transmission in men who still remain affected by syphilis, to now higher numbers from transmission related to heterosexual exposures. And females now account for more than half of all cases, which significantly impacts the overall risk of congenital syphilis. Then this slide outlines the age groups that are most at risk, and note that this doesn't include cases of congenital syphilis. So individuals in their 20s represent the highest number of cases, followed by those between 30 and 39, which really corresponds to our childbearing years. However, you'll note that cases are occurring in all age groups, and increasing cases in youth is particularly concerning. And as Dr. Roussin noted, infection rates in this endemic are really influenced by multiple overlapping social determinants of health, which aren't represented on these slides looking at the epi. But risk factors like housing, substance use, experiences of violence, and access to healthcare, they all play a role. And that systemic discrimination and stigmatization has really contributed to mistrust in many of the populations, which is really a barrier to testing and treatment of syphilis. So the first case of congenital syphilis was identified in 2015, and it was the first case in over 30 years. And then since then, the number of congenital syphilis cases has risen rapidly since 2017, with case numbers doubling from 2018 to 2019, and then doubling again from 2019 to 2021. The number of cases in 2022, again, is still being analyzed, so it's quite possible that these numbers will also change. And these case numbers represent both confirmed and probable cases. There are many more infants that are investigated for congenital syphilis, but they don't meet any case definitions. So this doesn't even begin to reflect the large amount of work that we know is occurring in follow-up. In 2020, the majority of all early confirmed congenital syphilis cases were observed in the prairie provinces of Alberta, Manitoba, and Saskatchewan. So our case numbers are really far too high and represent a real significant public health risk. I'll now move on to talk about screening. So this slide represents our recommendations for who to screen for syphilis, which is also outlined in the updated Manitoba Health Protocols. So the list includes people with consistent symptoms, contacts to cases, people with risk factors, including new or multiple sexual partners, and those diagnosed with other STBBIs. Those with ongoing risks should be tested frequently, every 3 to 6 months. Screening in pregnancy is particularly important, as well as in infants born to mothers or birth parents with reactive syphilis serology, as well as for all stillbirths. Overall, we recommend offering STBBI screening in the course of routine medical care, with special attention to those with risk factors. Normalizing screening in this way can reduce barriers to testing and the stigma associated with STBBIs, and that stigma really remains an issue and a barrier for individuals when they seek care. In addition, due to the volume of cases we're seeing, screening based on risk factors alone is going to miss a significant number of cases, as many present when asymptomatic or with lesions that really aren't noticed. Follow-up for contacts for testing and treatment is another really important component in our strategy to reduce the number of cases. Partner notification has public health benefits in disease surveillance and control. So when we find cases, we interrupt those transmission chains, but it also reduces the risk of a reinfection for the index case. So it's an important part of care for your patient and really in their best interest. The traceback period for syphilis is really dependent on the stage, which reflects how long an individual may have been infectious. And this is also in the syphilis protocol for reference if you're looking for it. Unfortunately, obtaining contact information is often not an easy task for a variety of reasons, as we talked about with stigma and mistrust. And once individuals are tested and treated by their healthcare provider, it can be quite challenging for public health to get that contact information. So the first point of contact with the case is generally the best opportunity to acquire this information. Cases are often unable to provide complete demographic details for contacts. They may not know their birth date or address, but the more information that's provided to public health, the more likely public health will be successful in locating that contact. So if you can try to provide the case with prompts to get as much information as possible, if they don't know their birth date, maybe they know the month or year or how old they are. Do they know what street they live on? If you wanted to find them, where might you look for them? Do you know their next of kin or someone who might help find them? Maybe they might know their profile on social media. They could even check their phone for clues, or they might even be willing to send their partner an online text message to get their contact information. Any of that information is really valuable to public health, so feel free to provide as much as you can. And we know that contact tracing is very challenging, and so we do appreciate and value the time you spend in obtaining this information. And in recognition of this, there is an extra tariff for completing the contact section of the STBBI provider form, which we'll talk about a little bit later in this presentation. As I said previously, screening in pregnancy is really critical in the prevention of congenital syphilis. So our provincial recommendation for syphilis screening in pregnancy is 3 times and should be done regardless of any previous syphilis test result. So the first test should be done within the first trimester in addition to testing for other STBBIs, and then screening again at 28 to 32 weeks gestation and again at delivery. And more frequent screening is indicated with ongoing risks. So if they're symptomatic, if they have another STBI, they have new or ongoing risks, or sexual contact with someone infected with or symptomatic of an STBBI. In some individuals, we recommend monthly testing as well as delivery. So if they're newly diagnosed with syphilis, including reinfections, or if they've had a previous syphilis infection but have received treatment during their current pregnancy. Our provincial testing rates during pregnancy have been steadily increasing, as shown in the slide here, and we'd certainly like to see that continue, with 62% of pregnant persons tested 3 or more times for syphilis in the first half of 2022. So I'll turn it over now to Dr. Van Caeseele to review syphilis testing and interpretation.
Thanks, Carol. Next slide, please. So now you're faced with a patient who either has risk factors for or signs and symptoms consistent with syphilis. So before we get into the more nebulous serology, we'll start with some of the more straightforward approaches. So the first is a PCR-based test. We call that nucleic acid amplification sometimes, just to be general about it. To do syphilis PCR, we ask for a flock swab, for that to be collected and placed in viral transport medium. And that can be collected from a mucocutaneous lesion, such as a chancre or a mucus patch, from a newborn's nasal secretions via a nasopharyngeal specimen, and from all manner of chancres that can be found all over the body. And that's submitted just as you would for any viral investigation, and we can get that result probably in about a week to you. And that would be considered diagnostic if PCR comes back positive. Next slide. So cerebrospinal fluid is submitted when suspect neurosyphilis or as part of the investigation for congenital syphilis. One normally asks for BDRL in that circumstance because that is the non-treponemal test that is really best studied for investigating CSF. But we will also automatically consider doing treponemal tests, particularly the FTA or fluorescent treponemal antibody test as part of our investigations. Syphilis PCR can be requested if you're highly suspicious of neurosyphilis and you might expect to see circulating or present treponemes in the CSF. So once again, it's just CSF and ask for syphilis investigation, VDRL, plus or minus syphilis PCR, and we will get that back to you. Pretty much any positive result is highly suggestive of central nervous system involvement. Next slide, please. Then there's serology. This is the easy one, right? So in years gone by, we used to use the classical algorithm, which meant we would start with a non-treponemal test and then confirm with a treponemal test. We've since moved into the 21st century and are using what's called the reverse algorithm, where we screen instead with the treponemal screening test. You might see it on the reports referred to as a chemiluminescent immunoassay, or CMIA. We get a positive or a negative from that. If it's the first time that they've had a positive, we'll confirm that with a second treponemal test called the TPPA, or treponema pallidum particle agglutination test. And that just helps to confirm that we're not dealing with a biological false positive. We then try to quantify, in some respect, to what degree treponemal infection might be present using the non-treponemal test. In the past, we had used VDRL, and we still do use VDRL for CSF quantitation, but from serum, we use the RPR. And so we will report out a quantitative result in dilutions, a 1-in-1 dilution to as high as, I think I've seen as high as 1 in 1,024 positive at some point in my life. It wasn't mine, mind you. It is important to know that a dilution in the lab can vary, 1 dilution up or 1 dilution down. So a 1-in-2 dilution can vary anywhere between 1-in-1 and 1-in-4 and be considered the same result. Next slide, please. There are a few places on the requisition where you can select syphilis screening. I think if you advance one more, you'll see that there's the STBBI panel, the prenatal panel, and the syphilis screen. So the STBBI panel is used in the event that you're concerned about sexual exposures or blood-borne exposures, and that allows one to look for hepatitis B, hepatitis C, syphilis, and HIV, all with one tick box. The prenatal panel is obviously meant for pregnant persons. What's different about that is that it does not look for hepatitis C, but it does look for rubella IgG, which one would expect in the prenatal panel. The syphilis screen selected alone is really just going to get you the syphilis testing that I discussed in the previous slide. You see chlamydia and gonorrhea is indicated on there as well. We do require a separate requisition for chlamydia and gonorrhea screening. We're trying to work out ways in which we can get this all done on one requisition, but at this point, 2 separate requisitions are required for 2 separate specimens. Next slide, please. And here's where it gets super simple, right? So once again, we're using the reverse algorithm. We'll start with that treponemal test, that CMIA. If it's negative, that either means there's no evidence of syphilis infection whatsoever, or it's just too early after exposure or too early in the very early stages of the disease for us to tell what's going on. But if it's positive, then you look for the RPR and the TPPA result. The TPPA being positive and the RPR being positive is pretty much as good as it gets in terms of serology to indicate that somebody has syphilis or has had syphilis. If the TPPA is reactive, but the RPR is negative, they may be still early in the syphilis course, only a couple of weeks perhaps, or this is old and successfully treated infection and the RPR has managed to fade down to 0. If just the RPR is positive, or just the TPPA is positive, you might also be dealing with a biologic false positive, but in particular, if only the RPR is positive and the TPPA is not, that's very suggestive of biologic false positive. And of course, if RPR and TPP are both negative, then it's looking like that treponemal test is possibly a false positive, but we have talked about how it could be early syphilis infection as well. We'll go through a few scenarios now. Next slide, please. Oh, before we get to some scenarios, let's talk about reinfection. Admittedly, reinfection is pretty difficult to sort out sometimes. So you get a patient with positive syphilis serology. One of the questions is, have they had syphilis before, or have they had positive syphilis serology before? If the answer is yes to that, then you really need to dig into the history, unfortunately, to sort out whether or not there's been subsequent exposures, adequate treatment, any treatment at all, or perhaps if there was immigration, because we never know just exactly how reliable immigration testing, particularly from other countries, or immigration-based syphilis treatment is. So if we see in that scenario whether or not we have supportive history of either adequate treatment or of subsequent exposure, we see consistent signs and symptoms, then typically we're going to treat that as a new infection, particularly if the RPR titers can be demonstrated to have increased by 4-fold. And we'll talk a little bit more about that later. Even in the absence of consistent signs and symptoms, if we see that there's an increase in RPR titer more than 4-fold or more than 2 dilutions, then that's highly suggestive of a new infection, reinfection, or possibly even a failure of treatment, although that's less common. Now, if we don't know about the previous RPR dilutions, or if we do, but they're not more than 4-fold higher, then we start to need to look more into their last treatment and the adequacy of it, and any exposures. If there is concern about exposures or of subsequent exposures, or if there's concern over adequacy of treatment, then chances are we'll go to repeat testing in 1 or 2 weeks to see what's happening with the titers, and we might have to consider empiric treatment in those circumstances. If, on the other hand, we're not finding any worrisome exposures, or if we're fairly convinced that their treatment was adequate, then we might just call this an old infection and monitor their serology accordingly. Next slide, please. So we have a few scenarios at the lab that we report out fairly commonly, so we'll let you know about some of them. So the first is the screen is negative. All you get is the CMIA result and an interpretation. As I said in one of the previous slides, this is most likely screen negative, no exposure to syphilis, but if there is a known exposure to syphilis in the last 1 to 3 weeks, we might not expect the antibody to be appearing yet. Next slide, please. So there'll be lots of discussion about how these are managed later on. So if we skip that, pardon me. So in this case, once again, the CMIA is positive, but the RPR and treponema pallidum antibody are non-reactive. That could either be a biologic false positive in this case, or it's just early syphilis once again, and we're waiting for lesions to appear. So we would typically retest in 1 or 2 weeks in this case. Now, if your patient's not the sort who's likely to show up again, you may decide to empirically treat if there's some high-risk activities in the background. But repeating in 1 to 2 weeks is perfectly fair. Next slide, please. So this is a scenario where all of the tests are positive once again, and we've got some high DILs in this case. That's highly suggestive of infectious syphilis, probably acute within the first year would be our suspicion. Just because you get a TPPA doesn't mean that the patient was tested within a year of exposure, of course. So the lab test and the lab result doesn't tell the entire story, of course. But either way, with a high DIL like this, chances are patient's going to need treatment regardless of what the story is. Next slide, please. Okay, more interpretations. This is fantastic stuff, right? So we got two patients here. Let's just put in the text at the bottom, so advance just a little bit more. So this one had positive syphilis serology in the past, and that's why you don't see a TPPA in this case. Though, despite the fact that the RPR is positive, we know this person had previous syphilis because a TPPA was not done. So this is going to clue a person into the idea that we might need to ask a few more questions about treatment and adequacy of treatment, and whether or not there's been any further exposures. Patient B is, oops, sorry, let's go back there. Patient B is a little bit similar in that we're not really sure whether or not they're an old infection or something that's in motion at this point. So we need a little bit more history. But in this case, the lab has done a TPPA because we have no prior history on this patient. So this is the one place where the lab actually has some information that you may not have, and it shows up whether the TPPA is done or not. Next slide, please. And let's just include some of the comments below, so advance a little bit there. So this is where we're getting to increasingly complex scenarios. So the patient was initially diagnosed in January of 2021 and then treated a month after. The DILs have fallen from 1 in 60, a high of 1 in 64 to a low of 8. So it's fallen at least fourfold. So that's looking good. If anything less than 1 in 16 would have been an adequate response in this time. And that happened over only 4 months. So that's a fantastic fall that suggests that this was either primary or secondary or early latent syphilis. However, a year later, not even a year later, we see that the DILs have risen remarkably, more than fourfold. This is highly suggestive of a reinfection. Possibly a failure of treatment. We don't see failures of treatment rebound quite so, fall quite so quickly and then rebound quite so high. This is more in keeping with the reinfection. Next slide, please. And we'll just advance a couple comments. There we are, perfect. And once again, now this is late latent syphilis. We haven't talked about late latent syphilis yet. What's different about late latent syphilis is, first of all, it's got a different treatment course. Usually three doses of penicillin is a week apart, is how we like to do that. But the other thing to know is that the RPR dilutions fall more slowly. It can take 1 to 2 years for them to fall to an acceptable level. And sometimes they seem to really take their time doing so. So in this case, it's 3 weeks later, 2 weeks later, pardon me. And we've treated twice. The DILs haven't really changed much. It looks like they've gone up, but in fact, remember, that's within 1 dilution of one another. So we consider that really the same. Now, if we got this result 6 months later instead, we might not even react to that yet. We might say, this is late syphilis. It's going to take longer to fall. Let's still wait and see what happens a full year from now. That being said, this person did not get their full 3 doses, and they really should get the full 3 before we can judge adequately what's occurring. Next slide. So I think next is Dr. Plourde.
Thank you. And so you heard Dr. Van Caeseele alluding a little bit to some clinical terminology, primary, secondary, early latent. So for those who are less familiar with the ways of diagnosing and staging syphilis, I'm going to give a few comments on the clinical presentation. Accurate staging is important. It determines essentially what kind of treatment they will need, a single course of penicillin treatment or weekly courses for 3 weeks. It's a different treatment depending on the staging. The follow-up that's needed and the kind of contact management, how far back you look for contacts and how much you look for, whether you look for contacts at all, will depend on whether they are a case of what's called early infectious syphilis or late non-infectious syphilis, which is less of an issue for public health and for transmission, but it's still an issue in terms of treating individuals so that they're cured of their infection. Could go on to the next slide, please. So the initial presentation of syphilis, the one that most people are familiar with, is a primary ulcer chancre, usually single, but can be more than one. And what's unique or interesting about the chancre, as opposed to maybe what you see with herpes and other genital ulcer diseases, is that the chancre is completely painless. It's firm to the touch. You can feel it when you touch it. It's slightly raised. It's an open sore, usually with a serous, non-bloody, non-purulent discharge. And again, the fact that it's painless makes it hard to detect and to undetectable. For example, if it's internal in the vagina, for example, for women, they might have primary syphilis and never know it. And even depending on how large the ulcer is, it may go easily unnoticed. It usually appears within 2 to 4 weeks after exposure to the infection. If ignored, if you leave the chancre alone without any treatment, it will resolve on its own. It will go away, but you're not cured. Your spirochete is simply going deeper now and disseminating through hematogenous dissemination, leading to secondary syphilis, which is dissemination of the spirochetes throughout your body, creating a systemic illness that can mimic so many collagen vascular diseases that it's very hard to diagnose secondary syphilis without a high index of suspicion. About 90%, so most people with secondary syphilis present like you see in the bottom right corner with a diffuse skin rash. Again, what's unique about the rash, it's easier to remember what a syphilis rash does not do rather than how a syphilis rash appears, because a syphilis rash can appear like anything. You name the rash, syphilis can mimic it, except for the vesicular rashes. So vesicles are not typical at all of a secondary syphilis rash, and itching is quite uncommon. Pruritus is quite uncommon with syphilitic rashes, but pretty well anything else goes. And especially if the rash is on the palms, the hands, or the soles of the feet, very few systemic diseases that cause rashes involve the palms or the soles. And so that is, again, increasing high index of suspicion for secondary syphilis. If in doubt, test. So do serology testing that you just heard about from Dr. Van Caeseele. Many people with their secondary syphilis rash will also have constitutional symptoms because of the disseminated spirochete. So they'll present with fever, malaise, pharyngitis, arthralgias, aches and pains, musculoskeletal symptoms, rarely with central nervous system symptoms, but if they do, that ups the ante, so to speak, because now you're thinking in terms of early neurosyphilis, which requires a more aggressive approach to diagnosis and much more treatment than syphilis that doesn't involve the nervous system. Next slide. Syphilis, though, having described the symptoms I just described to you, like pretty well all STBBIs, most syphilis presents asymptomatically, which is what makes it a challenge to diagnose and control the spread of syphilis, because most people with syphilis have no idea they're infected and yet are still able to spread the infection. So people with early latent syphilis, that simply means syphilis with no symptoms acquired within the last 12 months, that's what defines early latent. All of those people can spread their syphilis. It is infectious and sexually transmissible during the early latent phase. And untreated, about a quarter, as you can see, will go on to develop signs and symptoms of secondary syphilis. Late latent syphilis is simply defined as asymptomatic syphilis that is more than a year old, that was acquired more than a year ago. How do you know? You will only know mostly if people have had previous syphilis serology that was negative. And so if you know that a previous syphilis serology result that was tested less than a year ago, for example, was negative, and now they're coming up positive, then that pretty well tells you they have early latent syphilis. If the last syphilis test was more than a year ago or has never been done, sometimes it's hard to tell whether somebody has early or late latent syphilis. And as you see at the bottom of the slide here, when you're unsure about that staging, when you're not sure if their asymptomatic syphilis or latent syphilis is early or late, or it's on the borderline, we encourage people, and our public health nurses will also urge you to do this, is to stage them as early latent. So we do the contact tracing. It's reported as an infectious syphilis, and we do the more aggressive approach to preventing further transmission by doing the contact tracing. But we urge you to treat them as a late latent syphilis with the 3 weekly doses of benzocaine penicillin G instead of the single once dose. So you treat as late latent, but you stage them as early latent, and that's kind of a mixed approach that gives sort of the individual the benefit of the doubt, but also the public health approach to preventing further transmission. Next slide. Tertiary syphilis is currently very rare, probably because it takes 10 to 30 years for signs and symptoms of tertiary syphilis to develop, and we have not had outbreaks of syphilis long enough. We are approaching the 10-year point, and we may start to see in people who have not ever been treated for their syphilis, people presenting with late stages of syphilis that come decades later. That could include neurosyphilis and or cardiovascular syphilis that presents with ascending aortic aneurysms, or gummatous syphilis, which are like essentially syphilis tumors that can occur in any organ and present as a space-occupying lesion when it does present. Late neurosyphilis is the disease you probably studied in medical school that presents with either something called general paresis or tabes dorsalis. Essentially, general paresis being one of where the pathology is diffuse cerebral atrophy, and that's those individuals who present with early dementia and a whole host of psychiatric syndrome manifestations. And tabes dorsalis is the disease affecting the posterior columns of the spinal cord, leading to, again, loss of coordination, loss of position and vibration sense, and ataxia. When the cranial nerves are involved, as they often are, and the classical finding in the eye, for example, is the so-called Argyll-Robertson pupil, which is a pupil that reacts to light when it's shone in at the pupil, but does not react to accommodation. That's the classical Argyll-Robertson pupil. The next slide, please. So again, I won't go into, again, the details of early versus late neurosyphilis, but just a few important points to make. That neurosyphilis itself is not a stage of the syphilis. It can occur at any stage. It can occur at the time of the presentation of primary syphilis. It can occur during secondary, during any stage of latent syphilis. So neurosyphilis can occur at any stage. It's defined as early if it presents within 12 months of infection, and late if it presents later than that. Late, though, usually is 5 years or more down the road, more often than not. Neurosyphilis can be asymptomatic, and it requires a very high index of suspicion to diagnose. And one of the clues to the diagnosis, as was alluded to, I think, earlier in the presentation, is in people who are treated for syphilis, in whom the serologic response does not go down as fast as anticipated, or doesn't go down at all and stays fairly high with no other clues, no other symptoms, no evidence of reinfection. Person swears they've not had any sexual contacts, they've been treated adequately multiple times, their DILs are not coming down. You need to suspect neurosyphilis even in the absence of neurologic symptoms. And it is a diagnostic challenge, because the only way to confirm the diagnosis of neurosyphilis is with a cerebral spinal fluid examination, i.e. a lumbar puncture, that comes back positive for VDRL, for syphilis serology, or positive for syphilis nucleic acid amplification test, or PCR. Next slide. And so finally, when should you be looking out for neurosyphilis? I've already mentioned those previously treated individuals who do not achieve an adequate serologic response. You should include neurosyphilis in your differential diagnosis as something that might need to be assessed. People who have obviously neurologic symptoms, the ophthalmologists at the Misericordia Hospital often do diagnose eye manifestations, uveitis, and other ocular manifestations of neurosyphilis, and that can be the only manifestation of neurosyphilis. Or individuals with HIV who have a syphilis titer that's 32 or greater and low CD4 count defined as less than or equal to 350 should all be again assessed for suspected neurosyphilis. And then finally, all babies born with congenital syphilis automatically get the CSF evaluation to rule out neurosyphilis. And if and when we start seeing tertiary syphilis, those individuals will also need to be assessed for neurosyphilis. So I believe the next presentation will be Dr. Bullard, pediatric infectious disease specialist, who's going to tell us more about congenital syphilis.
Absolutely. Thank you very much. And to all the participants, a quick raise of hands. Who thinks that my voice and Dr. Van Kvitsiel's voice sounds the same?
Besides me?
I don't see any hands raised. So I always think of mine as a little bit richer, more baritone, and a bit lispy. But that's okay. Let's talk about congenital syphilis. And I think we're going to borrow a lot of the information that's already been presented by my colleagues. So if you would have asked me 10 years ago when I first started here in Manitoba, would I be seeing congenital syphilis? The answer would, of course, been a resounding no. We have no business seeing congenital syphilis, and it had been since 1977 since we did see it. And now, if anything, we're seeing around 200 to 250 syphilis-exposed babies per year. And you've seen the data for those that fall into the probable and confirmed cases as well. It's pretty straightforward when you think about what would place an infant or a fetus at risk for transmission of syphilis to them. And that's if the mothers or birthing parents have primary or secondary syphilis. And as Dr. Plourde alluded to, that implies that there's a lot more spirochetes around. And so if there's more spirochetes, it means it's more likely that the babies can ultimately become infected. Now, as you get into latent, it means that the amount of spirochetes around is a lot less. And so your risk drops quite a bit to between 40%. And if it's lately, it gets even lower than that at about less than 10%. Next slide, please. What's important for practitioners to really take to heart is the assessment. And the assessment is two parts. You're going to assess both the baby and you're going to assess the mother. And in those categories, you're going to have laboratory findings that you're going to look at, primarily syphilis serology, and a lot of different clinical findings as well. And ultimately, you're using that information to determine if a baby is considered high or low risk. And so when we think about lower risk, usually that is a mom who has a really good response to her treated syphilis. And it has to be treated at least 4 weeks before delivery. It also has to be a penicillin-based regimen. So if they receive something else, that's not adequate. As well, you're going to take a full look at the baby, and primarily you're looking for any evidence of congenital syphilis. The most common thing that we will find is typically a rash. And the rash, as Dr. Plourde alluded to, can be multiple different presentations, but I'd say the unifying feature is often that you see desquamation of the hands and the feet, and then a macular rash kind of all over the body. In addition, you're going to look and compare the maternal and the infant serology. And typically you want the infant's serology and the RPR to be at least the same, if not significantly less than mom's. If it happens to be 4 times over, then we move into the high risk category. When we think about what constitutes high risk, pretty straightforward. If you have a mom who's never had any prenatal care, that puts them at significant risk. An increasing problem that we have here in Manitoba is we do find moms who are positive. We treat them and they get reinfected. And that causes, of course, the risk for the baby to increase. If we find another STBBI, that's not unusual. And ultimately, if you see an HSV lesion at delivery, that is a very common finding by our obstetrical colleagues to put into their notes. And ultimately, it's often described also as non-painful. And so that kind of helps you distinguish. So the main risk factors that I want you to recall for your practice would be the lack of prenatal care, first prenatal visit late in pregnancy, a lack of maternal screening, lack of treatment. And then, of course, there's a lot of driving through injection drug use, primarily with crystal methamphetamine. Next slide, please. So which infants should syphilistrology be requested? So if you have, and this is already taking place, all moms and birthing parents and infants will have paired serology. And that's really important to get set up right up front, because if you're waiting for advice from the pediatricians or pediatric infectious diseases, that's just going to delay the entire process. And that's regardless if the infection was in the current pregnancy or if it was in a prior pregnancy. It's important to get it in the immediate postpartum period, but you don't have to rush. In other words, you can get it within a week if it happens to be in one of our northern or more remote communities, and we can still use that to determine whether or not a baby requires treatment. Next slide, please. So one of the key things too is to know when to refer to pediatric infectious diseases. So remember that a lot of women and birthing parents will be referred to pediatric infectious diseases before delivery. And that's where we go over what our plan will be in terms of the evaluation and potential treatment of their infants. But if we have a mom who was treated and diagnosed with syphilis not in the current pregnancy, we don't necessarily have to follow them. And that's particularly true if there are no concerns during the current pregnancy. If you're uncertain, by all means, you can let us know and you can call Pediatric ID and we'll be happy to walk through the case with you. Next slide, please. I think that's it for me. I think we're back to Dr. Plourde.
Thank you. So just 3 slides on treatment. So I'm just going to touch the key features of the treatment principles. Remarkably, this must be one of the only bacteria that since the 1940s, we're talking about a long time ago, has not acquired penicillin resistance. And yes, I hope I haven't jinxed it, but this spirochete is exquisitely sensitive to a plain old penicillin, but not just any old penicillin. So it's important to know that benzathine penicillin G or penicillin G benzathine is the treatment of choice. It's a long-acting form of penicillin. It does not penetrate the CNS, so it's not the treatment for neurosyphilis, but for early latent, late latent even, and primary, secondary syphilis, 2.4 million units. Pay attention, that's 2 injections because it comes in pre-filled syringes that contain 1.2 million units. So some clinicians in the past have made the mistake of just giving 1 injection of 1.2 million. That's only half the treatment. So you have to give an injection in each hip. Unfortunately, they're painful injections, and we haven't figured out a way yet to make them less painful. But for primary, secondary, and early latent syphilis, the treatment is a single treatment, 2 injections in each hip. For late latent syphilis, it's 3 weekly treatments of the double injections, and neurosyphilis requires IV antibiotics for 10 to 14 days, and that really is an IV consult for assessment and treatment. Be aware that benzathine penicillin G is not, go back to the previous slide, is not short-acting benzoyl penicillin G. That is the formulation used for IV use of penicillin, and it is not adequate treatment IM in a single treatment course like this. Ceftriaxone is the second-line therapy in penicillin allergic non-pregnant individuals. Pregnant persons cannot be treated for syphilis with ceftriaxone, nor with doxycycline. And an asterisk on doxycycline is some clinicians have figured that it's too onerous to give benzathine penicillin G because it hurts, because it's injections. Why don't I just give them 14 days of doxycycline? Doxycycline is not to be used as a convenient treatment. It's only a third-line choice when penicillin and ceftriaxone cannot be used and you have no other option. And finally, azithromycin isn't even on the slide, but you may read in books that azithromycin has or can be used to treat syphilis, but not in Manitoba. 100% of syphilis isolates in Manitoba are resistant to azithromycin, so forget about that. The next slide, please. So in pregnancy, to prevent congenital syphilis, which is almost 100% preventable by treating the pregnant parent, the treatment for syphilis in pregnancy is simply the same benzathine penicillin G weekly for 2 weeks only, unless you think the mother has latent syphilis, and then you would treat her with the 3 weeks. But if the mother has primary, secondary, or early latent, you would just need to give the 2 weekly double injection treatment. And pregnant individuals who are allergic to penicillin should not receive ceftriaxone or doxycycline, and the only treatment for syphilis in pregnancy that's available is allergy desensitization, and it works well. You can get it through with an allergy consult to help you with the desensitization procedure. And don't forget again to treat the sexual partners of the pregnant individual, or else they will just become reinfected, as we see frequently during pregnancy. And the next slide, you've heard already about the importance of following up after treatment, what we would call a post-treatment test of cure, by repeating the syphilis serology at preset intervals. I will refer you to the provincial protocol for this without going through the details, but you expect the RPR titer to come down at least 4-fold within the first 12 months after treatment. If that doesn't happen, if your titer remains high or settles at a level that is not non-reactive after some time and remains serofast, that's when you have to start considering, could they have neurosyphilis? Could there be ongoing exposure or reinfection, or is that a treatment failure? So again, the provincial protocol gives you good guidance on how to follow up people with different stages of syphilis and the DILs that you expect over time. The main thing is to be patient. DILs don't come down very quickly all the time. And sometimes you just have to wait and repeat the serology in a month or two before you decide whether you're going to retreat or assess for neurosyphilis. So back over to Dr. Carol Kurbis.
Great, thank you. So I just have a few remaining slides on mechanisms to report to public health. So all health professionals are required by law to report under the Public Health Act all STBBI cases, as well as contacts to chlamydia, gonorrhea, HIV, and syphilis to Manitoba Health. And all the treatment records for STBBI medications supplied by Manitoba Health are also required. So we've created a new STBBI provider report form for this purpose. And the form was really created to reduce the amount of information required from providers and focus on the information that's really critical to allow public health follow-up. It replaces a number of previous existing forms used. And so far the feedback on the form has been really positive. It shouldn't take more than a couple of minutes to complete. But to support the completion of the form, we've approved some tariffs, and we know everyone's busy. So for completion of the first part of the form, which has treatment, risk factors, and staging, there's a fee of $20. And then for reporting contacts to us, there's a fee of $30. So we're hoping that we get good uptake of receiving these forms, and thank everyone for doing that. And then as further incentive to complete the form, we're embarking on a project with Digital Health to transfer all the treatment records reported to public health to eChart. So because STBBI medications supplied by Manitoba Health are distributed directly by providers, they're not distributed through pharmacies, and they're not therefore recorded in DPIN and then not in eChart. And so we know that there can be challenges in accessing treatment records, particularly for syphilis. This can be problematic. So once you report the STI treatment for us on the form, we'll enter it into our Public Health Information Management System, or FIMS, and then we'll get these records transferred over to eChart to display along with the DPIN records. If there's any updates to treatment, by all means, send us an updated form so we can correct any of the treatment records. It's not live yet. We expect to go live within the next few months, and we're really hoping that this will be a real benefit to all providers, because we know individuals seek care in different places. So I'll turn it back to Dr. Roussin to wrap this up.
All right. Yeah. Thanks. Thanks, everyone. Thanks to the presenters. They're really great presentation. A lot of information there, and just again, we see that concerning epi. We see that's leading to congenital syphilis, which is really tragic to see here. But we all have that role, right? Early diagnosis, early treatment, even empiric treatment when appropriate, really has that ability to start breaking those transmission chains. Certainly testing and treating in pregnancy, we know is very effective at preventing the congenital syphilis. So a lot of great information here and a lot of resources. We have some contact numbers and emails if you have any questions. I don't see any questions here in the Q&A, but here's where you can reach any of these physicians. Public health, my email can always be reached with questions, and we can get some experts to reply to that. So we know we have this STBBI essentially crisis in Manitoba. If you haven't had a chance to see the presentation from on Docs Manitoba, you can find that on our communicable disease website or on Docs Manitoba's webpage. Really for STBBIs, test frequently, test one, test for all, knowing when to empirically treat, especially those that are high risk, and we can start breaking those transmission chains. And then again, how important it is with an individual in front of you who you're treating or suspecting STBBI, and treating them empirically, to let us know with that form who got treated. Let us know if you can ascertain any contacts. The quicker we can start our contact tracing, again, that's that early diagnosis and treatment. So really appreciate everyone's time. Again, thanks to the college for putting this on. Thanks to the presenters, and don't hesitate to reach out to public health, and we're happy to reply to that. And then look out for more of these webinars. We're going to have webinars on further on syphilis, another one on HIV, where we're seeing very concerning trends as well. And so thanks again. I'll turn back. I'm not sure if anyone from the college wanted to say any last words. Otherwise, thanks so much.
It's Anna. So thank you very, very much. It really is important that we keep all of this front and center. And for those of us who work in urgent care, these are things that we also need to remember and think about, because sometimes the presentation to emergency is the only one that we're going to get. So again, thank you.